Welcome back, everyone. We're going to continue down the pediatric series with discussion on pediatric trauma considerations. So, hallmarking the considerations needed when addressing pediatric trauma patients are the anatomy and physiology differences relevant to the pediatric patients. This makes injury patterns and responses significantly different from those seen in adults, and developmental stages of the pediatric patient can affect those responses. Blunt trauma is the mechanism of injury for most pediatric cases. Less muscle and fat for the pediatric patient leads to less protection against those forces transmitted. And so there's a higher risk for lower injury insults to lead to similar injuries in adults that would require higher force of impact. Falls are common for pediatric patients and a common cause of blunt force injury. And the injury will reflect the child's anatomy based on the height of the fall. For example, a 6-year-old playing on the monkey bars is most likely to sustain an upper extremity fracture when falling onto an outstretched arm. Internal or head injuries would be uncommon with that type of injury. Falls from a standing position usually result in isolated long bone fractures, but high energy falls can result in multi-systems trauma. Injuries from bicycle handlebars are typically produce intra-abdominal compression injuries because the patient tends to fall forward over the handlebars. Pathophysiology for traumatic injuries. So for motor vehicle crashes, this can result in a variety of injury patterns. And again, this is going to depend on the restraints and the positioning of the car. When you're assessing the pediatric patient post-automobile accident, not only should you inquire about whether or not the patient was restrained in the car seat or the appropriate booster seat, but was that seat also restrained? This is particularly important for car seats. If a car seat isn't attached to the vehicle, then it really just becomes a vessel for the patient to move around in within the vehicle. And as with all unrestrained passengers, pediatric and adult, you should suspect multi-systems trauma injury associated because of their movement around the vehicle. Assessment, we're going to start with the pediatric assessment triangle, just like we would for medical patients for pediatrics. So we're going to use the patient's appearance, the work of breathing, and the circulatory status based on skin presentations. Make sure we go through a thorough scene size up to gauge the mechanism of injury and the significance of impact from those forces. And life support interventions should be administered as you encounter them in the primary survey. Pneumothoraces can be present with penetrating trauma of the chest or upper abdomen. Advanced providers, paramedic providers for this can use needle decompression to help decompress the chest. Signs and symptoms for this can include tachycardia, JVD, and pulsus paradoxus. JVD being the jugular venous distension noted on the neck, and pulsus paradoxus is a reduction or an absence of radial pulse during inspiration. And this is created by the increased intrathoracic pressure caused by the pneumothorax and accompanied with inspiration, reducing cardiac output. For basic level providers and advanced EMTs, you can consider things like assisted ventilation or assisted oxygenation for these patients. Any trauma patient should be considered at risk for developing shock. Once ABCs are stabilized, you should continue your assessment with disability and AVPU, and then obtaining either the revised trauma score or Glasgow Coma score, depending on what's prevalent in your particular service area. Place a cervical collar on the patient for suspected cervical spine injuries and immobilize to a long spine board when indicated. Remember that spinal motion restriction has lost some favoritism with the long spine board in recent years, as it doesn't tend to really impact outcomes for cervical spine as much as one thought. So consult local protocols, local guidelines, and evidence and best practice, but be aware of cervical spine injuries and then the indication for spinal motion restriction. Perform your rapid head-to-toe trauma exam when needed. Make sure that you do cover the child, keep them warm. We've talked about temperature management in children quite extensively up to this point, so make sure you're keeping them warm. And then treat any fractures accordingly with splinting and immobilization. Some traumas are going to be load and go because of the severity of the injury and unstable condition. For these types of situations, you should perform life-saving steps on scene if you have to. So if it's a matter of seconds to minutes that these interventions need to be performed without causing additional harm, they should be performed on scene. But if they can be moved to be done en route, they should be done en route. There's very few indications or situations where it's relevant to stay on scene to do something like start an IV for EMTs and paramedics. The outcome for trauma patients is strongly correlated to time to ED arrival. And so that really should be your biggest concern there. All trauma victims with suspected spinal injury do require spinal motion restriction. If the collar is too big, it doesn't need to be placed, but you can immobilize patients on things like pediatric immobilizers, or for infants that are in a car seat, you can pad around the voids of the infant and the car seat and transport in the car seat itself. If the patient's stable, obtain additional history. Remember that your pediatric patients may not be great historians, so you may need to ask caregivers on scene or who was taking care of the patient during the time of injury to get more information there. Perform a more thorough physical exam en route. If the patients are stable enough, look for bruises, abrasions, and subtle signs of injury that can be missed. And this can include things like Gray Turner's or Cullen's sign, where you've got flank bruising or periumbilical bruising. Airway management and ventilatory support take priority over circulatory management. This is the hallmark of pediatric patient care. Most of the problems with pediatric patients arise from lack of oxygenation, from hypoxia. So ensuring airway adequacy and ventilatory adequacy are going to be most important. Tachycardia is usually the first sign of circulatory compromise in a child, and hypotension is often a late finding. Remember that pediatric patients can compensate well for a long period of time. So it becomes important to recognize those compensatory systems and do not wait till a patient decompensates to begin treatment. Rather, you should begin to adjunct treatment during that compensatory phase. For fluid management, so for EMTs and paramedics, establishing IV access and maintain perfusion, you can administer 20 milliliters per kilogram of isotonic crystalloid solution. Remember that for neonates and infants, we're going to drop that down to 10 milliliters per kilogram. Get a history before you administer fluid. As we talked about in cardiovascular emergencies, if a patient has an underlying cardiogenic disease, fluid can be harmful. So we need to make sure that we are assessing these patients appropriately and accordingly, and watching and monitoring following intervention. Pain management. Pain is often undertreated in children, and not just by pre-hospital providers, but by in-hospital providers alike. If the patient is in pain, we treat the pain, period. You can use assessment techniques looking at vital sign changes using things like the Wong-Baker FACES pain scale to help determine pain, but you need to manage the pain in your children. Remember that pain is not just an emotion or a sensation. Pain releases stress hormones, it releases cortisol, it mitigates healing process, it further destabilizes patients through the catecholamine response. So pain is more than just a symptom or an emotion. It's something that needs to be managed appropriately throughout the continuum of care. For burns, assessment and management are similar to these of adults in your pediatric patient, but understand that temperature regulation and burns are going to impact more significantly for pediatric patients because they have a higher skin surface to body mass ratio. Their surface area is much, much larger, and so their impact to burns or damage to the integumentary system can be more problematic than they would be for the adult patient for the same size burns or the same surface area burn. Be vigilant for worrisome patterns of injury or suspicious circumstances that can be a cause for abuse. Remember that your goal here is to treat your patient and get this patient into a more definitive care situation so that we can get additional resources for these patients that are indeed victims of abuse. Scene safety is going to be important. Make sure that you estimate the percentage of BSI. Younger children, you need to modify and account for the larger head size. So for infants, head and trunk each account for 18% of body surface area, while arms are 9% and legs are 13.5% each. And this changes as the child gets older. So when you're looking at estimating burn injury, you need to make sure to count the child's age and developmental status. Things that are suggestive of abuse, so mechanisms or patterns that are burned on the patient that don't match the presentation of the patient or the history of the patient can be an indication there and a suspicion for a child abuse. Make sure that you remove any burning clothing and support with 100% supplemental oxygen for burn patients in pediatric. Clean the burned areas minimally. We need to avoid lotions and ointments. Cover with burn sheets or clean, sterile, dry dressing. And then again, analgesia, pain management is important for these patients. And then make sure that they are transported to an appropriate medical facility. And ideally, this would be a pediatric trauma or a pediatric burn center if available in your area.